Hello and welcome everyone to tonight's webinar on GP management of pelvic organ prolapse, brought to you by Capital Health Network and gynecologist Dr. Omar Adham. First, I would like to acknowledge the traditional custodians of the land we're meeting on. I acknowledge and respect their enduring culture and the contribution they make to the life of this city and this region, and I pay my respects to their elders past, present and present. I also acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending tonight's event. So just before we start, as usual, participants have been muted and we're going to have a question and answer session at the end of the presentation. So please type all your questions into the Q&A section, not the chat section of your Zoom window. And we'll also put the presentation up on the Capital Health Network YouTube page in a couple of weeks. So you can share it with your networks or have a look at it if you've missed out on something. And CPD, so this is 1.5 hours of educational activities, and please self-report it to your CPD home. CHN will email you a certificate of attendance after the event, and we'd also love it if you could fill in the evaluation survey. And also just to highlight health pathways. So I'm sure you're all familiar with health pathways, but if not, it's a free guidelines and referral service for health practitioners. And we've got one that's localized to the ACT and New South Wales region. There's a personalized login, or you can do the generic login. The generic login is together, the word together, all lowercase, and the password is for health. And there's a health pathway for pelvic floor dysfunction and prolapse and sound. So now over to Dr. Omar Adham, which we're very lucky to have him tonight. So thank you very much, Omar. Omar is a skilled and accomplished gynecologist, and he's currently working as a senior gynecologist at the Canberra Hospital, and he's known for his expertise in complex urogynecology cases, as well as laparoscopic surgery and surgically complex endometriosis. He has made significant contributions through clinical research and teaching, and he also operates a private medical practice providing comprehensive gynecological care to a diverse patient population. So over to you, Omar. Thank you very much.
Thanks for the introduction, Leonie. Thanks everyone for having me. Tonight, I thought we will sort of more of a refresher and a GP's guide to the primary management of female pelvic organ prolapse. So we'll start with an introduction. The pelvic floor dysfunction includes urinary incontinence, fecal incontinence, obstructed defecation, sexual dysfunction, and female pelvic organ prolapse, which is the most common that is most likely to require a surgical intervention. The objective of this talk is to focus on the diagnosis and the management of female pelvic organ prolapse in primary care, with reference to etiology, prevention, and a broader clinical context. I thought we'd start defining the pelvic organ prolapse, where it's identified as a downward displacement of pelvic organs leading to herniation into and or through the vagina or the anal canal. The types of prolapse are divided into an anterior compartment prolapse, which includes cystocele and may include other organs, uterine or apical prolapse, and posterior compartment prolapse, and that's generally and more commonly includes rectocele and or an enterocele. The anatomical basis for a prolapse is it's really identified as a hernia through the levator hiatus, the pelvic floor muscle opening for the urethra, the vagina, and the anal rectum within the pelvis. Etiology of pelvic organ prolapse. It is multifactorial. The prolapse results from failure of the levator ani muscle support, vaginal structural integrity, and connective tissue defects, as well as pudendal nerve injury, which is typically from childbirth. The normal anatomy function for the pelvic floor is with a normal levator tone and vaginal depth. The upper vagina lies horizontally, and this creates a flap-like valve to resist the downwards intra-abdominal pressure. When a prolapse occurs, there's loss of levator tone, which reverts the upper vagina into a vertical position, and there's widening of the genital hiatus, and hence an increased reliance on just purely connective tissue. And when that tissue support fails, prolapse occurs. Just a couple of diagrams to the left of the screen. Diagram A demonstrates the anatomy of the pelvic floor support, and our interest really mainly is in the urogenital hiatus, and also the levator hiatus. So the urogenital is the anterior part of the pelvic floor, and that encases and supports the urethra, bladder, and the vagina, and then the larger muscle group, which is the levator hiatus, supports the perineum and the anal rectum. I thought I'd touch base and remind everyone about the risk factors for pelvic organ prolapse. There are general risk factors, which include advancing age, high BMI, generally BMI is above 35, menopause status, and low socioeconomic status. Obstetric risk factors is current pregnancy per se, labor-related risk factors, prolonged labor, particularly prolonged second stage, instrumental delivery. The main offender really is forceps delivery, and also high parity and large babies. Another risk factor, a group of risk factors, is those that increase intra-abdominal pressure, and that includes chronic cough, particularly in smokers and those who have got chronic lung disease, constipation and excessive straining and heavy lifting. Prior surgery, such as hysterectomy, has a 5 to a 7% increased risk of future vault prolapse, added onto a low-risk population. We'll talk about clinical diagnosis and clinical assessment of pelvic organ prolapse, also the staging system. So just wanted to make a comment about terminology. So the older terms such as cystocele and rectocele are less commonly used now, as there's anatomical assumptions. If we say a cystocele, we're referring to a bladder prolapse, where if you have someone who's had a prior hysterectomy, and you label that as a cystocele, where it's an anterior vaginal wall prolapse, there's generally in 50% of those patients a coexisting enterocele. So small bowel can come through anteriorly, for an example. And the same principle applies to the posterior vaginal wall. So we nowadays classify it by compartments. So it's an anterior or posterior and apical compartment prolapse. Symptoms, there are primary symptoms related to the physicality of the prolapse itself, and there are symptoms, secondary symptoms that relate to other organs as a result of the prolapse. So the primary symptoms, as we all know, involve a feeling of a vaginal lump or a bulge within the vagina, a dragging sensation, vaginal laxity or looseness, and painful intercourse or dyspareunia. Secondary symptoms could be urinary symptoms such as, cystocele related, such as straining to void, intermittent stream, and that's generally due to urethral compression or kinking, straining at stool, incomplete bowel emptying, digitation. These are generally due to a posterior compartment prolapse, particularly rectoceles, enteroceles, or rectal interception. Recurrent UTIs could be as a result of chronic high pulse void residuals from a advanced cystocele, and nocturia can happen from daytime accumulation of residual urine. So I'm going to talk about next the evaluation and the staging of pelvic organ prolapse, which can be confusing. So there are two mainstay systems for staging prolapse: POP-Q system and the Baden-Walker system. So the POP-Q system can be complex. It's classified or staged into 4 stages. So stage 0, no prolapse. Stage 1, the prolapse is descent is more than a centimeter above the hymen. So it's contained within the hymen, and it's about a centimeter above that. Stage 2, it's approaching the hymen, so a centimeter above and a centimeter below the hymen. Stage 3, where the prolapse descends more than a centimeter past the hymen, but it's confined within 2 centimeters, less than the total vaginal length. And stage 4 is complete eversion of the lower genital tract. So if it's a vault or if it's a uterine prolapse, you'll see the cervix protruding beyond 2 centimeters from the hymen. The Baden-Walker system is a lot more simpler. So it's 4 grades. 0 is there's a normal anatomy or position and no prolapse. Grade 1, descent halfway to the hymen, so mid-vagina. And then grade 2, to the hymen. Grade 3, halfway past the hymen. And grade 4, maximum possible descent for each side. This is an illustration of the POP-Q assessment or system. You can see in figure 1. To simplify the task, many of us limit ourselves to point BA for the leading edge of the anterior prolapse. So anterior has an anterior and a posterior point. So, and C for cervix, for C for the leading edge of the uterus or uterine or vault prolapse, BP for the leading edge of the posterior prolapse, and TVL or transvaginal length. Then the distance from the external urethral meatus to the anus is genital hiatus plus the perineal body, which seems to, and this is a very good measurement of the ballooning of the genital hiatus or the distensibility. So we really just refer by using BA and BP, which is the maximum point of descent. We use that in relation to the hymen. How do we, so the measurement or the, how to implement the POP-Q system clinically by examination. The measurements are taken with generally a ruler or an estimate, but we do it manually during a maximum Valsalva. So always ask the patient to perform a Valsalva maneuver, wait for 5 to 6 seconds, let the prolapse demonstrate maximum descent, and then the hymen is our reference point. So relative to the hymen, values below the hymen equal positive prolapse advancing, and values above the hymen are recorded in the negative. You may use fingers as a speculum to assist in reducing if you have a large cystocele and you want to assess an apical vault prolapse or uterine prolapse or a rectocele, and probably best to reduce that so you can make get access and better views and more accurate assessment. The hiatal metrics, so the genital hiatus equals the urethra to the fourchette measurement, and the PB is the fourchette to the anus. So both of those combined together, that measurement reflects the hiatal ballooning, and that's quite important for subsequent management, which is the high hernial portal size. Just some images to illustrate the top left, the anatomy without a prolapse, and then to the right there's a you can see anteriorly the bladder protruding, forming a cystocele or a cystourethrocoele, and then there's a rectocele where the posterior vaginal wall has protruded, quite an advanced prolapse, and then uterine prolapse, so reaching the hymen, and then an antrocele, so small bowel coming through a posterior compartment prolapse rather than the anorectum, and a vaginal vault prolapse. And then we'll sort of talk about an overall clinical assessment. So expectation for a general health assessment. Symptoms assessment is best to use a validated pelvic floor questionnaire, and there's many of those. They're very, very good. They do assess the bowel, bladder, and the sexual function, and symptom botherness. Examination and a POPQ or a Baden system documentation is very helpful, and obviously identifying any coexisting pelvic pathology, that some of those can actually lead to prolapse-like symptoms, and also checking on cervical cytology. Assess for mucosal ulceration, particularly in the advanced prolapses, and evaluate the anal sphincter tone. And it's also an opportunity to assess for rectal prolapse if there are significant bowel symptoms present. These are indications to refer to a specialist as soon as you can, I guess, and not be persuaded to manage it yourself as a primary carer. So quite advanced prolapses as stage 3 and 4, because they can be quite complicated. Patients who have history of radical pelvic surgery, pelvic radiation, suspected fistula. If you have identified a pelvic mass when you're investigating the prolapse, those who have recurrent urinary tract infections or avoiding dysfunction, those who also present with abnormal bleeding, such as postcoital or postmenopausal urinary retention, hydronephrosis, tissue ulceration, and bowel symptoms that warrant colonoscopy, such as dyschezia and management. So the first line management observation is acceptable and very appropriate for milder prolapses. Generally, those are asymptomatic. They are encountered at times when you're mostly if you're performing an examination to undertake a co-test or a vaginal swab for some reason. I generally don't really occasionally bother even disclosing a stage 1 if they're purely asymptomatic, unless I see risk factors, and then I'd recommend lifestyle changes. So weight reduction is one of the critical aspects of conservative approach. I talk about good bowel habits, so avoiding constipation, heavy lifting, chronic coughs, avoiding chronic strains. Educate them about correct positioning for voiding and defecation. Supervised pelvic floor muscle therapy, or pelvic floor exercise, is recommended in all stages of prolapse. There's no solid evidence to shed more light on its effectiveness in managing advanced prolapses, but it's well established as a preventative for prolapse and potentially stabilize very early stages, as in stage 1 asymptomatic prolapse. So if there's access in the community to a physiotherapist or a nurse continence advisor, then that's preferable, even though nowadays there's plenty of online educational handouts you can provide. Ranscock and Ayuga particularly have very good ones. And then we talked about observation, lifestyle changes, supervised pelvic floor exercise, and then pelvic organ support pessaries, which I'll go into details. I'd like to focus on that. I think it's quite important for our GP community. These are useful across all stages, and they do require regular view. Local estrogen for women with hypoestrogenic symptoms or urethral prolapse is recommended. I generally recommend local estrogen if patients have urinary symptoms with the prolapse, particularly urgency, urgent continence, frequency, recurrent UTIs, dysuria, dyspareunia. They have a well-established effect on these. And now I want to talk in more details about vaginal pessaries and the management of prolapse. So the best practice is a few points here to remember or to note. A pessary trial can be offered to all women with symptomatic prolapse. The success of the pessary achieving its purpose may vary, and that's based on the individual patient characteristics. Before fitting a prolapse, these are the two main, most important questions that will determine your choice of the pessary and the expectations and what you want to achieve and what the patient wants to achieve. So it's the sexual activity that determines, with vaginal penetration, that determines the type of the pessary you're going to use, and also are they capable of self-management. Indications and contraindications for pessary. So common indications, patient's preference to avoid surgery, need to delay surgery, such as being on a long public waiting list. Patients that are poor surgical candidates, so the very elderly, those who have got other significant comorbidities. Recurrent prolapse with preference to avoid reoperation. Vaginal ulceration due to severe prolapse. Prolapse during pregnancy is another indication for the use of pessaries, and desire for future fertility. Prolapse surgery is certainly not recommended prior to completion of family, because there's a much higher recurrence rate. It may not be appropriate to use pessaries in the following conditions. Also, patients who have local vaginal infections, if there's a presence of a foreign body in the vagina, such as a mesh exposure, that increases the risk of infection. If the patients are non-compliant or unable to attend regular follow-ups. Sexually active women who are unable or unwilling to manage their own pessary. So we tend to forget that, a 48-year-old, very fit, physically fit, athletic, sexually active patient with an advanced prolapse, if she is not willing to manage the pessary, then it really shouldn't be recommended. Unexplained genital tract bleeding, so that's got to be investigated and prior to considering pessary management. The types of pessaries. Pessaries are classified as either support or space occupying types. So most of them are made from silicone, which is autoclavable and hypoallergenic, and some may be latex. So it's always worth checking for latex allergy, obviously, if you're considering those. So the support pessaries, examples of those, and there are many. The most common we use ring pessaries, Schatz, Hodge, and Girong. The ring pessaries are the most commonly used, and the reason behind it is they have a wide range in terms of size. They are easy to fit, and they're inexpensive, and they're often suitable for intercourse. The other types will probably be considered and may help with more advanced prolapse, but are harder to self-manage. The space-occupying pessaries, examples of those are the Gellhorn or Gellhorn, the donut pessaries, and the cube. The Gellhorn is the most commonly used, and it's best for advanced prolapse stage 4. It's more effective than the support pessaries with a wider genital hiatus, rectoceles, and also short vaginas. These are examples of many different types. You can see the most common would be really the Schatz, which is I, the cube, and the Gellhorn, J, and the donut. So pessary fitting. So I think it's quite important for you guys to familiarize with that, particularly those who have an interest in managing pessaries. In other states, we have a lot of GP units who actually have a pessary clinic. We have a pessary clinic, a physiotherapist-led pessary clinic at the Canberra Hospital, which works out really well. But I think it's quite good, and you'll find this informative. So we'll talk about the fitting. The fitting really is, it doesn't matter how fancy they make it, it is really a matter of trial and error. We try and estimate the size, and I'll come to this shortly. And the way we do it, we empty the bladder, we assess we stage the prolapse, and then you would, in an ideal world, do a pulse void residual if there are any concerns about retaining high PVRs. We'll measure the vaginal length and the genital hiatus. The genital hiatus and the vaginal length are the most important measurements in determining if you're going to use a supporting or a space occupying and which type. Typical choices, advanced prolapses, stage 2 or 3, a ring pessary, and the most commonly size used is a 3, 4, or 5. They go from 1 to 10. Stage 4, a prosidentia or a wide hiatus or a post-hysterectomy vault prolapse. The ring or the other support pessaries rarely stay in place, so we tend to default to a Gellhorn. And the fitting principles include using the smallest size that relieves the symptoms and is retained. If it's too large, it's too painful, it'll expel. If it's too small, it won't contain the prolapse. If the pessary falls out and you feel there's room, then go up a size. If it's too uncomfortable, downsize it. If the ring fails, try it again in a different size. If it repeatedly fails, consider switching to a Gellhorn. Always when you do the fitting, ensure there's a finger gap between the edges so there's no tension and subsequent erosion. And after the insertion, test the fit with Valsalva, coughing, and I get them to stand up and do a walk around the practice. And then occasionally you can also perform a cough test. Well, we generally perform a cough test once you've fitted the pessary to see if there's any occult urinary stress incontinence. What are the risk factors for a pessary trial failure? Well, previous prolapse surgery, so that tends to narrow and shorten the vagina. Prior hysterectomy shortens the vagina, short vagina under 6 centimeters, and a wide vaginal introitus or a hiatus that's more than 4 centimeters. What do we do for follow-up? Well, I generally have them come back in 1 or 2 weeks post-insertion and just assess for comfort, if expulsion, and de novo urinary incontinence. Routine follow-ups are every 6 to 12 months. That's what we do here in Canberra Hospital or in the ACT in general. And it's basically for pessary cleaning and to assess complications. Then the modern pessaries, particularly the ring ones I'm referring to, are now manufactured latex, and they're really designed to be, washed, cleaned, and refitted. So I try and manage each patient with 2 pessaries, so they will clean one, and then we just keep swapping those rather than purchasing pessaries, every 6 months. And that seems to work well, and there's no increased risk of infection. What are the complications of vaginal pessary use? Vaginal discharge or odor. These are often inflammatory. They're not infectious. A lot of times they're mistreated as infection. They are inflammatory. We manage them by removing the pessary. We provide or we prescribe low-dose vaginal estrogen or a pH lowering agent, and that generally deals with the odor. Vaginal bleeding, and the causes could be vaginal atrophy, insertion removal trauma, or vaginal mucosal erosion. You've got to rule out pathology, so take out the pessary, treat with vaginal estrogen if it's due to atrophy. Vaginal erosion is another complication, which is excoriation of the mucosa, and that it presents itself with bleeding or irritation. It occurs more with the larger ones that are really, really tight. So we tend to remove the pessary for 4 to 6 weeks and treat it with local vaginal estrogen. A pessary failure is also a complication, obviously, or an adverse outcome where inability to retain the pessary or relieve the symptoms. There are some serious and uncommon complications of vaginal pessary use, which is pessary incarceration. This tends to occur more with the gel horn pessaries. Fistula formation, again, more with the gel horn pessaries, or if the pessary is left in situ for 2 years or a year and a half, particularly the elderly. Urinary or colonic obstruction can also happen if it's too large, and again, more often with gel horn pessaries. And it's, as I mentioned earlier, more likely in older women with severe atrophy and non-compliance with follow-up. Let's talk about the choice of pessary and troubleshooting. Again, start with the ring pessary for the first fitting. We tend to explain sexual activity is possible. Those who have an apical prolapse, who've had a prior hysterectomy, we try and use a ring with support. So there's the hedge has a bit of support to it, because it's really, really difficult for them to retain a pessary. If urinary stress incontinence is present or newly developed, then we use a ring with a knob to lift or elevate the bladder neck or the urethra. Now, what do we do? How do we troubleshoot a pessary when it expels? So assess how long the pessary remained in situ and when it was expelled. So expulsion during straining may not indicate incorrect sizing, but just increased pressure. Evaluate for comorbidities, and so if they're constipated, manage that to reduce the straining and prevent recurrence. And give the woman the choice to discuss with her whether she's willing and able to reinsert the pessary after expulsion, and check if the pessary was comfortable and supportive, as it still may be suitable. So you can reuse the same size. What if the pessary fails to support or is uncomfortable? So ensure the correct size and adjust accordingly. If unsuccessful, you can try a different type of pessary. And the choice of pessary, again, depends on sexual activity whether or not they are sexually active. Sorry. This is going to shed some light again on the choice of pessary for two groups: those that are sexually active and those that are not. So those that are sexually active, vaginal penetration is possible with non-stem pessaries, such as the ring, a dish pessary with or without support, and a Schatz pessary. We tend to avoid space-occupying and stemmed pessaries, as these will limit sexual activity, such as the cube, the donut, and the gel horn. So I generally prescribe a ring or a Schatz for the sexually active, and a cube. I always start with a cube for the non-sexually active. It's considerations that are quite relevant and important will be self-management, and that may be preferred, but space-occupying types are often difficult to self-management, particularly the gel horns. They're impossible to self-manage. We nowadays really we've moved away from the hard plastic pessaries. They're all silicon-based, so they're quite softer and more flexible. For the non-sexually active women, any type of pessary can be considered, with or without a stem, and that's referring in particular to the gel horn. Support or space occupying types, they're both fine. The principle is really to select a shape and a material that fits comfortably, easy to remove and insert, provides optimum support for patient anatomy, and as the gel horn and the shelf pessaries are available in short or long stems, and that the choice of that is determined by the vaginal length. So if it's a short vagina, you use a short stem. This is just an illustration of support pessaries and space occupying pessaries. So you can see the ring pessary on the top left, suitable for really also all degrees of prolapse, but more commonly first and second degree symptomatic uterovaginal prolapses. And then the Girong pessary, it's suitable for cysticeles and recticeles, with or without uterine prolapse. And this is a flexible or a bendable or a moldable pessary, so you can shape it. And then there's top right is the Hodge pessary. It's particularly used for those who have a really narrow pubic arch. And then there's a cube pessary, bottom left, for more advanced prolapses, and then a donut and a gel horn. You can see that how they are meant to sit within the vagina. A very brief description of the available surgical options. In general, they're categorized into two groups: an obliterative and a reconstructive surgical approach. The obliterative is what we call colpoclaesis, so closing down the vagina. And then there are many reconstructive abdominal transvaginal procedures. As I said, there are multiple surgical options available. It's really the principle of no single approach fits all. So each woman's condition and goals are unique. Each prolapse by itself is really very different. So the best option for one woman may not be appropriate for another. Decision making is often complex because the prolapse may involve multiple vaginal compartments, and it can cause a variety of symptoms. So we tend to individualize the surgical care, and in general, the obliterative procedures really are indicated or suitable for the very elderly, those that are medically unfit, and you want to do the bare minimum, and when they're the sexually inactive elderly women. We tend to explain, obviously, the permanency and the irreversible nature of these obliterative procedures. So surgical options and the recurrence. So numerous surgical approaches exist, including there's a vaginal or abdominal surgical approaches or routes to repair prolapses. Some of them may include the use of surgical graft materials or mesh per se. The prognosis of a surgical prolapse repair depends on the symptom severity, or mainly the extent of the prolapse, the surgeon's experience, the patient's expectations. So the recurrence and the reoperation rate after initial surgery can be up to 30%. There are a certain group of patients who are at a higher risk of recurrence, and that's when you operate or on younger age, so below 60, and also advanced prolapses such as stage 3 and 4, they are more likely to reoccur or for the surgery to fail. So reconstructive surgery, many approaches. I'll talk about the transvaginal approach. So that includes an anterior colporrhaphy for anterior compartment prolapse, so posterior colporrhaphy plus minus perineal body repair. So these two are native tissue repairs. There's no mesh utilized, and it really entails think of the prolapse as a hernia, opening the hernia sac and reinforcing support under the base of the hernia with native tissue with dissolvable sutures. Combined prolapse, gynae and colorectal team, which we don't do very often. That's for complex prolapses with rectal interception and so on. The prolapse repairs, there's the option of uterine preservation versus removal of the uterus. There's been a move over the last few years to uterine preservation, even in those who have completed fertility, because by experience and based on some recent evidence, the uterus is a better anchoring point for prolapse repairs. So, and an apical repair is not repaired by a hysterectomy, and we'll go through that shortly. So I tend to, and 99% of my prolapse repair, and with the most advanced cases, preserve the uterus. And I've seen over the last 7 or 8 years that the outcomes are better, the recurrence rates are much lower. With uterine preservation, I generally, aside from a rectocele, will always emphasize the critical importance of apical support. So an anterior prolapse or a cystocele, a posterior prolapse or a rectocele, a uterine prolapse, you cannot repair them without apical support. So the apical or the vaginal vault support there are transabdominal procedure to do that. It's either an open or a laparoscopic approach and it's called a sacrocolpopexy. So colpopexy is vault sacrum, and it's basically surgically dissecting out the vaginal vault and attaching a mesh onto the vault and suspending the vault onto the sacral promontory. That's a very, very good operation, and we do that laparoscopically nowadays. It's generally preserved for those who have had recurrent prolapse 2 or 3 times and have had 2 or 3 vaginal prolapse surgery. They've lost the vaginal length completely. It's almost a frozen vagina, and you have, a vaulty version. Sacrospinous fixation, so that is attaching the vaginal vault or the apex onto the sacrospinous ligament within the pelvis, which is a higher level of support, and that's done transvaginally, and that really should be the first approach. And I offer that, and a lot of us should, and perhaps do offer that with a repair of a large cystocele or a large rectocele or a significant vault prolapse. So we approach it vaginally. It's a pretty straightforward operation. On the comparative data, when you look at the long-term recurrence rate for this operation versus the laparoscopic vault suspension are comparable. And then there's heterosacral ligament suspension. You could do that laparoscopically or vaginally. So we tend to use native tissue repairs as above in women with obesity, pelvic radiotherapy, and prior prolapse repairs. So wanted to touch base on how we manage stress urinary incontinence in prolapse patients that are undergoing surgical repairs. So we've got to try and identify that at the initial consultation. With overt stress urinary incontinence, I know the literature recommends discussing continence procedures that are done concomitantly with the prolapse repair. I don't do that because I feel, or again, from experience, if you do a proper anterior compartment or cystocele repair, you will tend to see that within 3 months, the stress incontinence may well improve. So I generally counsel patients and recommend we repair the significant prolapse and then reassess 4 to 6 months after. And if there's significant stress incontinence, then we manage that conservatively, and subsequently they may require a minor procedure to address that. So I think that's the end of the presentation. Yeah, thank you. I'll take some questions now.
Thank you very much, Omar. So I just had a question. I thought I'd start off and then other people can type their questions in. So if someone does undergo surgery, what kind of advice do you have for them when they're recovering? Because I imagine that in a postmenopausal woman, the tissue repair isn't as speedy as the traditional 6 weeks. So is it a longer time? When are they allowed to go back to exercise or
Yeah, it's a very good question. So, I quite counsel them in details about that. So it's a very common question, and GPs are stuck in the middle. Really, the first default of patients is back to the GP if they haven't had adequate post-op instructions, I guess. So, regardless of if they were young or old, the time taken for tissue for complete recovery is 3 months, 12 weeks. And saying so, what I tend to encourage them to do is they can lift items or weights, or do tasks that entails carrying weights up to 5 kilos straight away. That's not a problem. I encourage them to assume, the correct position with defecation and also strain when it's required. We do provide them with laxatives for the first few days to open the bowels and maintain soft bowel motions, and some dietary advice. And then we do so the first 6 weeks is that's what the expectation is it's a light weights, about up to 5 kilos. And then we do a 6-week checkup, and then we can up that to 7 to 8 kilos light exercise. So from week 4 onwards, they can do, yoga classes, Pilates, these kind of non-weight bearing. But for weight bearing, really, it's 3 months.
right? Yeah,
Mm.
that's useful. And so driving and things like that,
Yeah. Again, I recommend they do not drive until the 6-week check.
right? Yeah. So it's
Yeah,
kind of like having a cesarean, but a bit more.
yeah,
Yeah,
correct. Yeah,
yeah,
yeah, yeah.
yeah,
Because it's all about the downward pressure, really,
yeah.
on the prolapse repair.
And what
Um,
about do you see if people start? You were talking about local vaginal estrogen. If you
mm,
see people start systemic HRT, do you also see a benefit to their pelvic floor?
it's, as I said, there's really no good data to illustrate uh, substantial benefits in improving uh, prolapses that are
Already there.
stage 2 onwards, yeah.
Yeah. Yeah.
We don't have evidence. It doesn't harm.
Yeah.
I think I mean, I recommend it, but I'm upfront. You've got to be upfront and say to them, your stage 2, 3, and 4 is not going to go away with your prolapse. Your
Yeah.
stage 2 may remain as stage 2, and
Yeah.
pelvic floor may have something to do with that. Um, it's primarily for those who come with no prolapse counseling for how do they prevent future prolapse. Pelvic floor exercise is good. Stage 1, that's also beneficial.
Yeah. And you talked about examining the patient for the prolapse and doing the 5 to 6 second Valsalva. So
Mm,
that's the patient lying down on their back. If they still feel like they've got a prolapse and you can't see it or detect it lying down,
mm.
do you get them to stand up and
Yeah, correct.
examine them?
So that's right. So 20 to 25% of prolapses in a tense environment, the pelvic floor is quite tense. So that's protective to start with, though it might downgrade the stage of the prolapse, but equally lying flat. I mean, the Valsalva, when it's done correctly, it's meant to simulate, well, provides the maximum pressure down onto the prolapse. So that really should demonstrate prolapse. But if the patient says, well, I don't get it that way, and I don't get it first thing in the morning. I
Yeah.
get it at the end of the day. Then you know that it's gravitational, really. And so I tend to, if someone reports clinically what sounds like an advanced prolapse, seeing a lump, having a bulge, then I'd certainly get them to stand up and walk around and part their legs and Valsalva in an upright position.
And see if you can see it there.
Mm.
And then there's been a lot of kind of technology, I think, in the non-medical space about pelvic floor exercises. Have you seen those things like PeriFit? They're kind of like a pessary you put in and it gives you biofeedback about you tensing your pelvic floors. Do you have any opinions on them?
Yeah, look, we're not really very much exposed to that.
Right.
Yeah, uh, but again, I don't think there's evidence again that they're not trials driven, those devices.
Yeah.
Um, so
They're
I can't really
social media
comment
driven,
on
I think.
those. Yeah, that's right.
Yes, right.
But
Uh,
look, we do. Uh, I thought this is probably an opportunity to also mention that. I mean, um, have taken most of the Eurogynae service at the Women's Health at the Canberra Hospital, and we have a beautiful or a great bunch of physiotherapists that are led by Ella. So we were discussing the other day, for those who have an interest, we can potentially organize a pessary workshop if,
right.
if
Yep.
there's enough numbers. So we're
Yep.
happy to do that. It'll be myself and a couple of lead physios, and I mean, it'll be a lot of preparation, but if
Yep.
you have maybe put it out there, and if there's good enough interest, then we could do that. We could do it
Yeah.
even at the Canberra Hospital for those who want to gain more knowledge, practical knowledge about managing prolapse, pessaries for prolapse in the community.
That's got a thumbs up from someone in the audience. So perhaps audience members, if you could express on the evaluation survey, if you'd be interested in that, we could pass it on to Dr. Adam
Yeah,
and see if there's interest.
and then we
Yeah,
run a workshop, so
yeah,
advertise that through the network. Yeah,
yeah, that would be good. And then just, of course, the elephant in the room, mesh.
yeah,
So is the mesh that you use now
sure.
different or
Yeah,
it's
so that the mesh. Well, where do you start with the mesh?
yeah.
I mean,
But
it's
I think a lot of people would probably, if they were, I mean, that would be something that patients would ask.
correct.
And they
Yeah,
do ask if they're
yeah,
thinking
yeah,
about having a repair.
that's right. Yeah, so
Um,
I
yeah,
don't really offer it
yeah,
uh, anymore. But periodically, there might be the one case every 2 to 3 years now, and that's a very complex products case. So there are others who have the infrastructure and offer it all the time, and it's a
yeah,
primary choice where it should not be. So the summary or the gist of the mesh is that a few years back, there were concerns about the use of the mesh, and then there were lawsuits that followed, and then there was an outcome. The government looked at it, and then recommendations came through the uh, Australian Health Commission. So there's a very good pack of information that we provide to patients who have prolapse. And that has gone in great depth and detail about the available options. So I generally will talk them through the prolapse. I will make a recommendation, and then I will provide them with that information. Then I'll send them away and have them read it, and then test them on it when they return, and have them make an informed choice. So, but the summary of it is, a lot of the manufacturers have abandoned offering the mesh. At the end of it, just before the mesh saga came out, they fine-tuned it, and there was a beautiful, lightweight mesh material that was used for the complex laparoscopic prolapse repairs and for the large cystocele repairs. And they were very, very good. There were no issues with those. And there remain no issues with those. So when this occurred, government went and audited that, and there were a lot of clinical trials looking at adverse outcomes. And the outcome of it is do not offer transvaginal mesh for prolapse until further evidence about its safety is available. Offer a bladder sling or the TVT for urinary stress incontinence. That is completely fine, and there are no concerns. It is a very well-established procedure. It has the highest success rates, and it's the least invasive. So it's very, very good. In my prior talk for urinary stress incontinence, we touched base on the available treatment options, and this the urethral sling or bladder sling are the most successful and the least invasive. So the outcome was, as I said, don't use vaginal mesh. We have cleared the bladder slings and the laparoscopic sacrocolpopexy using a surgical mesh. But the mesh manufacturers stopped when they just fine-tuned a very appropriate mesh. So those who do it now would use a mesh that's designed for abdominal hernia, which is what we used in the very early days. But yes, back to your question, we don't use vaginal mesh for prolapse repair now. We use, if a mesh is to be considered, or a surgical mesh, it is to be a laparoscopic sacrocolpopexy only, with or without a hysterectomy.
Right. Yeah. Thanks. Yes, a complicated topic. Yeah.
Yes, it is. I mean, the point equally to make is, I think for the GP community, familiarizing with what they have had at the operation is quite important. Preoperatively, the counseling should be done by a specialist, because it's really complex. And if you ask 10 different urogynecologists about a surgical approach for a cystocele, I'll give you 10 different approaches. So it's all about experience, what you're familiar with and how good it works, and equally what the patient wants. But for GPs, it's important to familiarize at least with what they have had, what's the surgery, and also what potential complications can arise. So, which I didn't put in my presentation. I apologize for that. But I didn't want to focus primarily on surgery, and that's why. But 9 out of 10 prolapse repairs are transvaginal. None of them will include mesh. The most common complication is a vault hematoma, the most common complication. Anyone with bleeding, scan them, make sure they haven't got a collection. If they do have a collection, it's a small collection. Clinically, they're not infected. Conservatively manage it. You don't even need to refer them. That's what you do for those. Infection is really rare. Discharge has been managed, that we see a lot as infection. I would highly recommend, infection, you have to have inflammatory markers that are raised. You have to have, abdominal tenderness, an odor, a very abnormal discharge. I generally wouldn't treat unless I get symptom swabs that, there's confirmation in microbiology.
Mhm.
Um, Dysuria is very common without a UTI from catheterization at the time. Urinary retention is to be very mindful of post repairs as well. Yeah.
Yep.
Mild
Uh,
incontinence, they can be reassured and reassessed, on their 6-week follow-up.
yeah. There's a question here. Where can we order pessaries from? Where can we order pessaries from for patients who have lost theirs and got them interstate if they know the size and type without having to refer to CHS for fitting? And also for trial and error pessary fitting, will there be a cost for the patient? So two questions.
Yeah. Well, the pessary is costly. I mean, you have to, I think, I can't recall, but different depending on the type of it. You as a primary carer or anyone who I don't. I mean, I don't know about others, but we don't. So we don't charge them on the initial consult. So we'll fit the pessary, and if it expels, then we'll carry the cost. So I don't charge them.
I
Uh,
had a quick look while you're speaking
yeah.
about different pessaries, and I think there's some places online you can order them from.
Yeah, so
Yeah,
there's I can't recall the who we use. There's a couple of suppliers for the most common pessaries. I'm happy to get back to you on that.
yeah,
I'll email you a couple of
yeah,
suppliers, but there's mainly two. Yeah,
yeah.
and you buy them. We order them online, and there are there are a couple of brands we use, but there are a couple of medical suppliers. So you get them through a medical supplier, not the actual manufacturer or the brand itself.
Right. And the second one is, yeah, so if they go to CHS for trial and error pessary fitting, is there a cost?
No, those are
No, no.
public patients.
Yeah. So,
That
yeah,
are-
if they go privately, there'll of course be the consultant cost
Correct. Yeah.
and possibly the pessary cost. Yeah. But if they
Yeah.
go
Yeah.
public, then there'll be
When
no
they're
cost.
referred publicly, they're treated as public
Yeah.
Medicare patients. So
Yeah. Okay, I think we're done for the questions tonight. Thank you so much. I learnt so much there. I didn't know there were so many different types of pessaries and so many shapes and sizes. And that was really useful as a GP and being more attentive to patient symptoms. And certainly as a female GP, we do a lot of pap smears, a lot of
that's right.
CSTs. So we're kind of in a good position to look for these things. And it's good to know what some of the referral pathways are for patients with problems. And so we'll wrap it up there. And thank you so much, Dr. Adam, for your talk tonight. It was, again, as I said, very interesting. And just to let everyone know that there's 1.5 hours of educational activities for your CPD home to report. Please fill in the evaluation survey and let us know if you would like to have a workshop on pessary fitting. It's very kind of Dr. Omar to offer that. And in a couple of weeks, this should be up on the Capital Health Network YouTube page. So, yeah, that's everything. Thank you so much. Okay,
Thank
good
you,
night.
Lynn.
Thanks.
Thank
Bye.
you.